Welcome to the Noted Pharmacist, your trusted platform for comprehensive pharmacy and medical education. Today, we'll dive into antihypertensives, the cornerstone drugs for managing hypertension, with a focus on their mechanisms, classifications, and clinical applications. Be sure to watch our companion video, featuring a 10 MCQ quiz for effective revision, linked in the description below. By the end of this video, you'll understand the pharmacological basis of antihypertensive therapies. You'll be able to classify antihypertensive drugs based on their mechanisms of action. You'll recognize the clinical indications for each major class of antihypertensive drugs. Additionally, you'll grasp the pharmacokinetics and pharmacodynamics underlying these treatments. You'll identify common adverse effects and contraindications associated with antihypertensive medications. Lastly, you'll evaluate therapeutic considerations for individualized hypertension management. With these objectives in mind, let's transition to an overview of hypertension. Hypertension, commonly referred to as high blood pressure, is a chronic medical condition characterized by persistently elevated arterial blood pressure, which increases the workload on the heart and blood vessels. Left untreated, hypertension is a significant risk factor for cardiovascular events such as myocardial infarction, stroke, and heart failure, as well as renal damage and other systemic complications. The table presented here is just to emphasize the severe complications of untreated hypertension. It outlines quantified risks, clinical consequences, and pharmacological interventions essential to mitigating these life-threatening outcomes. Early and targeted therapy is crucial to improving patient outcomes and preventing systemic damage. Pharmacological treatment plays a pivotal role in controlling hypertension by targeting the underlying pathophysiological mechanisms contributing to elevated blood pressure. By reducing vascular resistance, cardiac workload, or both, these treatments help preserve organ function and prevent the progression of end organ damage. Consequently, they significantly enhance patients' quality of life and reduce the burden of hypertension-related complications. Antihypertensives classification. The management of hypertension involves a variety of pharmacological agents classified based on their mechanisms of action. The major drug classes include angiotensin-converting enzyme (ACE) inhibitors, angiotensin II receptor blockers (ARBs), calcium channel blockers (CCBs), thiazide diuretics, beta blockers, alpha blockers, direct renin inhibitors, and central alpha-2 agonists. Examples of commonly used drugs in these classes include enalapril, lisinopril, and ramipril for ACE inhibitors, and losartan, valsartan, and candesartan for ARBs. For calcium channel blockers, the frequently prescribed agents are amlodipine, nifedipine, and diltiazem, while hydrochlorothiazide, chlorthalidone, and indapamide are common thiazide diuretics. For beta blockers, typical options include atenolol, metoprolol, and bisoprolol. Alpha blockers such as doxazosin, terazosin, and prazosin are reserved for specific indications, as are aliskiren, the primary direct renin inhibitor, and central alpha-2 agonists like clonidine and methyldopa. We also have a class called direct vasodilators like minoxidil and hydralazine, which are reserved for severe or resistant hypertension due to their potent effects. These drugs expand the therapeutic arsenal for tailored hypertension management. Mechanisms of action. Let's briefly explore the mechanisms of action for the various antihypertensive drug classes previously outlined. Angiotensin-converting enzyme (ACE) inhibitors lower blood pressure by inhibiting the conversion of angiotensin I to angiotensin II, a potent vasoconstrictor. This reduction in angiotensin II levels leads to decreased systemic vascular resistance and aldosterone secretion, thereby promoting vasodilation and natriuresis. Angiotensin II receptor blockers (ARBs) work by selectively antagonizing the angiotensin II type 1 (AD1) receptor. This blockade prevents vasoconstriction and aldosterone-mediated sodium retention, reducing blood pressure without directly affecting bradykinin metabolism. Calcium channel blockers (CCBs) inhibit L-type calcium channels in vascular smooth muscle and cardiac myocytes. By reducing calcium influx, they induce vasodilation and decrease myocardial contractility, which collectively lowers systemic vascular resistance and cardiac output. Thiazide diuretics act on the distal convoluted tubule of the nephron, inhibiting the sodium chloride symporter. This results in increased excretion of sodium and water, reducing plasma volume and subsequently decreasing blood pressure. Beta blockers antagonize beta-adrenergic receptors in the heart, leading to a reduction in heart rate, myocardial contractility, and renin release. These effects decrease cardiac output and inhibit the renin-angiotensin-aldosterone system, RAS, providing dual benefits in blood pressure control. Alpha blockers selectively block alpha-1 adrenergic receptors on vascular smooth muscle, resulting in vasodilation and a subsequent decrease in peripheral vascular resistance. This class is often used in combination therapy for resistant hypertension. Direct vasodilators relax vascular smooth muscle, leading to vasodilation and a reduction in systemic vascular resistance, which helps lower blood pressure. They are typically reserved for severe or resistant hypertension due to their potent effects and potential side effects, such as reflex tachycardia or fluid retention. Examples include hydralazine, often used in combination with other agents, and minoxidil, which is highly effective but associated with significant adverse effects like hypertrichosis. Direct renin inhibitors, such as aliskiren, inhibit the activity of renin, the enzyme responsible for converting angiotensinogen to angiotensin I. This directly suppresses the RAAS and reduces blood pressure. Central alpha-2 agonists stimulate alpha-2 adrenergic receptors in the brainstem, reducing sympathetic outflow. This leads to decreased peripheral vascular resistance and heart rate, effectively lowering blood pressure. Pharmacokinetics. We will examine the pharmacokinetic profiles of each antihypertensive drug class in detail. ACE inhibitors like enalapril exhibit moderate oral bioavailability and undergo hepatic conversion to active metabolites. They are primarily eliminated by the kidneys, necessitating dose adjustments and renal impairment. ARBs, such as losartan, have variable oral bioavailability and are extensively metabolized in the liver via the cytochrome P450 system. The active metabolites contribute significantly to their antihypertensive effects. The table presented here is just to summarize the pharmacokinetic profile of ARBs in clinical use. It highlights absorption metrics, bioavailability differences, metabolic pathways, and excretion details. Calcium channel blockers, including amlodipine, are well absorbed orally and highly protein-bound. They are metabolized in the liver by CYP3A4 and have a long elimination half-life, allowing for once-daily dosing. The table presented here is designed to succinctly summarize the pharmacokinetic profile of calcium channel blockers, emphasizing their relevance to hypertension management. It highlights key properties such as absorption, distribution, metabolism, and excretion, illustrating their influence on therapeutic efficacy. Thiazide diuretics like hydrochlorothiazide exhibit good oral absorption and are minimally metabolized. They are excreted unchanged in the urine, making renal function a critical determinant of their efficacy. The table presented here is just to summarize the pharmacokinetic parameters of thiazide diuretics in hypertension management. It outlines their absorption, moderate lipophilicity, minimal hepatic metabolism, and renal clearance profiles. These metrics highlight their suitability in patients with functional kidneys and minimal hepatic involvement. Beta blockers such as metoprolol are metabolized in the liver primarily by CYP2D6, with significant interindividual variability in bioavailability. Their elimination half-life necessitates individualized dosing schedules. The table presented here is just to provide a concise pharmacokinetic overview of beta blockers used in hypertension. It summarizes absorption, distribution, metabolism, and excretion with specific examples and critical insights. Central alpha-2 agonists like clonidine have high oral bioavailability and are widely distributed, crossing the blood-brain barrier to exert central effects. They are excreted both renally and hepatically. We want briefly look at therapeutic goals in hypertension management. The primary goal of pharmacological management of hypertension is to achieve and maintain target blood pressure levels, typically below 130/80 mm mercury for most patients. This reduces the risk of cardiovascular and renal complications, leading to improved long-term health outcomes and quality of life. The ideal blood pressure should be below 120/80 mm mercury in normal individuals. Indications and clinical uses. ACE inhibitors, such as ramipril, are first-line agents for hypertension, particularly in patients with diabetes or chronic kidney disease due to their renal protective effects. ARBs, like losartan, are preferred for patients who cannot tolerate ACE inhibitors due to cough or angioedema. Calcium channel blockers, such as amlodipine, are ideal for managing hypertension in patients with isolated systolic hypertension or angina. Thiazide diuretics, like chlorthalidone, are often used as initial therapy for uncomplicated hypertension due to their proven efficacy in reducing cardiovascular events. Beta blockers, such as bisoprolol, are indicated in hypertension with comorbid conditions like heart failure or postmyocardial infarction. Alpha blockers, such as doxazosin, are reserved for resistant hypertension or patients with concomitant benign prostatic hyperplasia. Direct renin inhibitors, like aliskiren, are an alternative for patients who require additional RAS blockade. Central alpha-2 agonists, such as clonidine, are used for resistant hypertension or hypertensive emergencies. Let's take a moment to explore the treatment guidelines for hypertension. First-line treatment. For the management of hypertension, angiotensin-converting enzyme (ACE) inhibitors, calcium channel blockers (CCBs), and thiazide diuretics are typically recommended as first-line treatment options. The table presented below is just to provide a concise summary of the first-line pharmacologic management of hypertension. ACE inhibitors, such as enalapril or ramipril, are particularly suitable for patients under 55 years of age and not of Black African or Caribbean descent. Calcium channel blockers like amlodipine or felodipine are preferred for patients over 55 or those of African or Caribbean origin due to reduced efficacy of ACE inhibitors in these populations. For patients with fluid retention or a risk of edema, thiazide diuretics like indapamide or chlorthalidone are effective options. Dosage adjustments should be based on the patient's renal function, age, and overall cardiovascular risk profile. Second-line treatment. When first-line therapies fail to achieve target blood pressure, combining an ACE inhibitor or angiotensin II receptor blocker (ARB) with a CCB or thiazide diuretic is recommended. For example, losartan 50 to 100 mg once daily, or candesartan 8 to 32 mg once daily, paired with amlodipine provides effective synergy in reducing blood pressure. Such combinations address different physiological pathways, enhancing treatment efficacy. Third-line treatment. If blood pressure remains uncontrolled, triple therapy involving an ACE inhibitor, or ARB, a CCB, and a thiazide diuretic is advised. For instance, ramipril, amlodipine, and indapamide can be used together to target multiple pathways. In patients resistant to triple therapy, the addition of spironolactone, 25 to 50 mg once daily, or another potassium-sparing diuretic may be considered, particularly in cases of primary aldosteronism or resistant hypertension. Impact of comorbid conditions. The presence of comorbid conditions like chronic kidney disease, CKD, diabetes, or heart failure significantly influences the choice of antihypertensive therapy. For example, ACE inhibitors such as lisinopril, 10 to 40 mg daily, are prioritized in CKD due to their renal protective effects. Conversely, beta blockers like bisoprolol, 5 to 10 mg once daily, are more suitable for patients with heart failure with reduced ejection fraction, HFrEF. In diabetic patients with hypertension, ARBs such as irbesartan, 150 to 300 mg daily, are preferred due to their ability to prevent diabetic nephropathy. We want to look at safety considerations for antihypertensive therapy, including side effects, warnings, contraindications, and drug interactions. Common side effects of antihypertensives. ACE inhibitors often cause dry cough, hyperkalemia, and angioedema. ARBs typically avoid the cough seen with ACE inhibitors but may still cause dizziness, hyperkalemia, and renal impairment. CCBs are associated with peripheral edema, flushing, and constipation. Thiazide diuretics can lead to hypokalemia, hypercalcemia, and gout. Beta blockers may cause bradycardia, fatigue, and cold extremities, while alpha blockers can induce postural hypotension and dizziness. Central alpha-2 agonists are known for sedation, dry mouth, and rebound hypertension on abrupt discontinuation. Serious adverse and warnings. The table presented here is to provide a concise overview of critical adverse effects linked to antihypertensive drugs. Serious adverse effects include angioedema with ACE inhibitors and ARBs, requiring immediate discontinuation and supportive care. CCBs, particularly non-dihydropyridines like verapamil, can exacerbate heart block in patients with underlying conduction abnormalities. Beta blockers may precipitate severe bronchospasm in asthmatic patients, necessitating caution. Regular monitoring of electrolytes, renal function, and heart rate is essential to minimize these risks. Clinicians should educate patients on recognizing warning signs, such as sudden swelling or difficulty breathing, which may indicate life-threatening reactions. Management of side effects. For ACE inhibitor-induced cough, switching to an ARB like valsartan, 80 to 160 mg daily, can resolve the issue while maintaining blood pressure control. Peripheral edema caused by CCBs may be mitigated by dose adjustment or co-administration with a diuretic. Patients experiencing fatigue from beta blockers may benefit from a gradual titration of the dose or switching to a cardioselective agent like nebivolol. Renal function must be monitored, especially in older adults and those on multiple medications. Drug interactions. ACE inhibitors and ARBs, when used with potassium supplements or potassium-sparing diuretics like spironolactone, significantly increase the risk of hyperkalemia. Concurrent use of beta blockers with non-dihydropyridine CCBs like diltiazem may exacerbate bradycardia or heart block, necessitating careful monitoring. NSAIDs may blunt the antihypertensive effects of diuretics, ACE inhibitors, and ARBs, particularly in patients with CKD. The table presented here is just to elucidate critical drug interactions among antihypertensive agents. Lastly, we want to look at emerging therapies. Emerging therapies, such as angiotensin receptor neprilysin inhibitors, ARNIs, like sacubitril/valsartan, show promise in resistant hypertension by combining dual mechanisms of action to enhance blood pressure control. Recap. Now that we've explored the topic of hypertension, let's take a moment to recap. We've covered the first-line treatments, such as ACE inhibitors and calcium channel blockers, discussing their mechanisms and dosages. We then delved into second-line options like thiazide diuretics and their role when initial therapies are insufficient. Additionally, we explored third-line treatments, including beta blockers, emphasizing their tailored use based on patient profiles. We also examined how comorbid conditions, such as diabetes or heart failure, influence therapy choices. Furthermore, we detailed the common side effects and serious adverse reactions associated with antihypertensive drugs. Finally, we explored emerging pharmacological agents, such as sacubitril/valsartan, Entresto, providing insights into future treatment options. In conclusion, the management of hypertension remains a cornerstone of cardiovascular health, requiring a deep understanding of drug classes and patient-specific considerations. Mastery of these principles is essential for effective clinical practice and improving patient outcomes. Be sure to check out our next video on drugs used in angina, where we'll explore their mechanisms, therapeutic use, and clinical applications. For further reading, we highly recommend Katzung and Trevor's Clinical Pharmacology, a detailed and insightful resource for understanding drug mechanisms. Rang and Dale's Pharmacology offers comprehensive coverage of pharmacological principles, ideal for students and professionals alike. Additionally, refer to the British National Formulary, BNF, for the latest dosing guidelines and clinical recommendations. Thanks for watching. If you found this video helpful, don't forget to give it a thumbs up and share it with others. Subscribe to this channel and hit the notification bell so you never miss an update in the series that we are doing. For more learning resources, check the description below. See you in the next video.